Well, good afternoon, and thank you for joining us today for the June 25th, 2014 City Club of Bellingham program, Chemical Dependence in Whatcom County, the Changing Landscape, Counseling and Treatment Options. So our two guest speakers are getting seated, and we want to share briefly with you that this June program is the second in a two-part series. First was a few months back, and this one is looking at the community impacts of drug and alcohol abuse. In January 2014, Vermont Governor Peter Shumlin devoted his State of the State address to Vermont's full-blown heroin crisis. In February, the national news media mourned the death of an award-winning actor and director, Philip Seymour Hoffman, from acute mixed drug intoxication. Today, we're going to explore the chemical dependence landscape in Whatcom County with professionals Carole Wells and Lex Rivers, who have been working for decades in this field, and for most of those decades, many of them here in Whatcom County. So they're going to bring us a fresh look at the bring us a fresh look at the snapshot of drug use and chemical dependence and the demographics in Whatcom County, and explore what we know about the nature of the problem and discuss some of the available treatment options here in Whatcom County. So you do have some papers on the table that give you some indication of a special program we have here in Whatcom County. We're very fortunate to have a countywide behavioral health program. It's funded by 1/10% of the Whatcom County sales tax. The youth and adult behavioral services that are provided by these funds focus on prevention, intervention, treatment, and aftercare. And so those handouts on your table are just some background information about the program that's offered through the jail and one that's offered through all the county schools. So our speakers today are going to give us another snapshot from another constellation of the community who might need these services. They're going to speak about their own experiences, and we've asked them to address a number of questions that we provided to them in advance. They're going to share a little bit about the landscape of chemical dependency as they know it, and then we're going to follow up with a few questions from myself, put together by the program committee, and then we'll put the questions out to all of you, and we have some folks who'll bring microphones around to get your questions. So as I begin, I'm going to introduce each of our speakers individually. I'll introduce Carole first, and then Lex. And I'll give a little brief snapshot that they gave me about what brought them to work in this field, why they decided to spend a career caring for people who are suffering with abuse and addiction issues in their home, in their family, or even in their own personal life. So again, I hope you've had a little refreshment. Please feel free to get up and refresh your glass or let people know if you need a little spot of tea. But we're going to carry on, and we're going to give each speaker about 15 minutes, and then we'll have time enough for all of you to get some questions in. So can folks hear okay? Okay, great. So I'd like to start by introducing our first speaker, Carole Wells. She's a CDP MA, and Carole has a master's in family systems and a degree in applied behavioral science. In the 1980s, Carole worked with programs like Recovery Northwest and developed and implemented intervention programs in all of the Whatcom County middle and high schools. She also taught chemical dependency counseling courses at Whatcom Community College and Western Washington University. And I will disclose, honestly, I met Carole when she worked at Recovery Northwest in the 80s, so we go back a ways. And Carole was attracted to the field of chemical dependency counseling and treatment at the age of 12, when she had contact with a family counselor in a treatment program for her mother. It was the first time Carole was ever able to talk about the alcoholism in her home, and the counselor helped her to understand alcoholism, and it helped to break through the isolation. The relief Carole felt was indescribable, as she tells it to me. Somewhere in Carole's child mind, family counseling, specifically in the addictions field, became a career choice. And in 1977, she entered the mental health track at Western Washington University. She actually started working in the field since 1980 as an intern in Western Washington University's psychology program. And over the past 24 years, she owned and operated Chambers and Wells Counseling Center, the West Coast Counseling and Treatment Center, and she currently works with individuals and families as a clinical supervisor at the Belair Clinic here in Bellingham. So Carole, welcome, and if you will, share folks a bit about the landscape and journey that you've had in your career here.
Thank you, Mary. Can you hear me okay out there? Okay. I was asked to look back over the years, and so I sat down one night and thought, well, this should maybe take half an hour. Well, 3 hours later, looking back over the history, and I felt like I had been at that time working for 35 years that night. The changes that have occurred in this field are just amazing. I have spent my whole time working with chemical dependency in Bellingham, mostly, and some in Whatcom County. And so what I thought would be interesting would be to put together a kind of a brief summary of some of the changes that have occurred and some of the highlights that really shifted the field of counseling in chemical dependency. As Mary mentioned, I did start as an intern in 1980 at Olympic Center. It was an inpatient treatment program, and it was the only program here in Bellingham. 1980 and through the 80s, the idea was that there's no way that anyone could seek help and be successful in an outpatient program. So a lot of inpatient programs all throughout the country were offering their services. At that time, it just seemed like, insurance companies would pay. It was kind of a carte blanche. If you had someone coming through treatment and you felt they needed 40 days instead of 30 days, that was okay. So inpatient treatment was the way to go, and a lot of the staff at the inpatient treatment centers had some specific training, but a lot of it were AA, kind of not volunteers, but AA members, Alcoholics Anonymous members. In 1983, Nancy Reagan had a program, and maybe you remember the Just Say No program. And with us in the field, it was kind of like, yeah, okay, Nancy, you're kind of out there, but oh well. But what happened at that time, she had sponsored a program called Chemical People. And this was a program that went in almost every county in the United States. And it was very professional. It was put on. They were looking for volunteers to be chairpeople of the program. And they had trainings in Seattle. And so myself and another person, Susan Berry, decided we would co-chair this. And this was an attempt to get the word out that adolescents, in fact, did have chemical dependence problems. Before that, treatment for adolescents was pretty minimal, if it was at all. So Chemical People was a program that was put on 2 different nights in 1983, and we attempted to get both of the high schools, Seahome and Bellingham, to sponsor one of the nights. Well, we had a terrible time doing that because people going to Seahome said, well, we don't have a problem, it's Bellingham, and vice versa. So we got, no, we can't do that. But we finally got them together and the school board together, and they agreed reluctantly to sponsor one of the nights. It was a huge success. People in the community came out, and this was a real turning point in the nation for people looking at getting help for adolescents. And if you are helping adolescents, families come along with those adolescents. So it was a huge turning point at that time. From that program, there was a school curriculum called Here's Looking at You Too that went into every school, and it was education. It was a prevention program. They had counselors, intervention counselors, prevention counselors in every school, high school, and most of the middle schools. So that was a huge, huge thing that happened for the field. Eventually, insurance companies found out that, hey, they were putting out a lot of money that they didn't want to put out. Surprise, surprise. And so they, in Cleveland, developed an index that was monitoring treatment, that you had to be accountable to say that if a person needed 20 days, that you're not just going to blanket give them 30 days. So they put together, actually it was guideline, I guess you'd call it, for the people in the chemical dependency field, that you had to justify, number one, if they were chemically dependent and what kind of treatment, how much they needed. So that was a huge thing. In the beginning, alcohol and drug counseling was separated. It was at two different agencies. And around this time, there was a merger of the two, of recognizing that, alcohol is a drug, and so dealing with those two issues is the same thing. So in the 80s and 90s, you might remember, there was a real scare about cocaine, the cocaine epidemic, and around the same time, meth. Lots of meth houses were discovered in the area, and there was, a lot of programs that were really trying to specialize in treatment for those various drugs. Outpatient, by this time, there were several outpatient centers, and they were also recognized as being a very good option for a lot of people. Dual disorder was looking at mental health and chemical dependency, that the two of them weren't necessarily separate issues. And so there was a merger starting to happen with those two fields of mental health and chemical dependence. Family treatment also was seen as being important. And as Mary mentioned, my background was really truly on a personal level and then professional level of understanding the loneliness that occurs with families who have addiction, and especially going back that far, talking about it, getting help. It was kind of very difficult for people to do that, and so family treatment started to be incorporated in treatment programs, inpatient and outpatient. I want to just say that the most exciting thing for me, I believe, is all the research that's been done in the last 15, 20 years. We could not, as counselors, understand why people, when they stopped one addiction, would move to another addiction. If it was behavioral, if it was food addiction, relationship addiction, gambling addiction, we couldn't understand exactly what was going on, why that happened. With the research in neurobiology, we found out that there is actually changes that occur in the brain when a person becomes addicted to anything. And so therefore, we were able to look at that as a treatment model to really address that and improve the way we approach treatment with people. It's just been ongoing, and it has been really exciting to help people understand that truly, it is a disease of the brain. Hard to describe it was a disease because it didn't seem like cancer or diabetes, but when you're looking at the neurobiology of addiction, it was a valid point and very important point. What I want to kind of end up with is that as a result of all these changes that have occurred, merger of mental health and chemical dependency, looking at outpatient programs, the effectiveness of it, there are currently several programs that are out there, and one is Suboxone, and I think Lex is going to speak to that. And this is for opiate addiction, which is very epidemic in this area especially. Also, it's called medically assisted treatment, where there are numerous medications that can help alcoholic and addicts actually curb their cravings and help them get into recovery and stay in recovery. Something that I was really excited about hearing was, this is just in the June 6th Scientific American, there's a newly discovered chemical that disrupts drug-related memories that trigger relapse. Our bodies produce a protein called actin, and this specifically acts on all the memory storage. now they're doing research, and now it's just on rats, but they're doing research and looking at developing a chemical that interferes with that memory storage of drug-related memories, specifically drug-related memories. Now, starting off way back in 1980, it was like we heard that maybe one day we'll find a gene that we can actually identify and actually stop addiction. It was kind of like totally unheard of at that time. And right now it hasn't happened. But the exciting piece of all this for counselors, people in the field, and especially for alcoholic addicts, is that there are new medications coming out, there's new research, which really gives us hope, and it makes me really feel hopeful about the field as we continue to learn more and more about it and improve our treatment. So even though this topic might not be the most uplifting topic, for me it feels very uplifting because we have been able to help families and addicts and alcoholics in a way that we didn't think we could before. So I'm going to stop here. There's some other new programs that are in other places in the United States and Canada that are very successful that we're looking at bringing to this area. So I'm glad you're all here. And what we used to say is that in a population, you can kind of guess that about 1 in 4 people have been affected in some way from alcoholism and addiction. So I'm so glad you're all here, and hopefully you can take the message of hope to someone you know that might need it. So thank you.
I'm going to ask Carole a few questions before you get... I want to follow up on a few things, Carole, because you had such a breadth of history about not just this community, but the field in general. And I'm wondering if you might share a little bit about what treatment or approach has been most effective for the kinds of clients you serve now.
Okay, right now I retired, but I didn't really. I am working in private practice. I'm working mostly with families right now. And it's pretty well individual and family treatment, but there are so many different programs around that are really easy to work with. Lex has one program that we often look at referrals, and combination of the mental health and the chemical dependency. And with the healthcare reform changes that are occurring, there's real positive things that are occurring of looking at blending the mental health, chemical dependency, and the medical model. So you can get the whole picture of, what is going on with the person.
Okay. And can you share a little bit about how availability of treatment options is affected by the socioeconomic status of your clients or clients who would like to get service?
A lot of that right now with the healthcare reform is kind of an unknown of where it's going to go. I was talking to a couple of people the other day that said, well, it sure has made it a lot harder with some of the programs being shut down that were really dealing with low-income, perhaps indigent people. And some of the programs have been shut down. And there's development happening, but as everybody knows, that takes time. So I really don't know what's going to happen.
And one other is a bit of a follow-up, given that 1 in 4 might actually have been touched by this challenge, and treatment is accessible but sometimes not affordable. Could you describe the cost to the community that you've seen from chemical and alcohol abuse and dependence?
I recognize people that are in the legal field and school and medical field here today, and it's no surprise that the cost to the community in not just pain and suffering, but actual cost of the emergency room, people ending up in court, people ending up in jail, people ending up in prison. It's tremendous. It's a tremendous toll on our society. And some of these things that we're looking at in other places that have really fully developed programs that are doing very innovative kinds of things. I just want to mention one program in Seattle. It's called the East Lake Housing Program. And this is specifically for people who have gone through treatment several times and haven't been able to be successful. And they're kind of the revolving door patients that we see over and over and over again in treatment. And what they have down there, and they have had going for perhaps 10, 15 years, is housing. It's right downtown. It's a housing apartment. And these are for that clientele who somehow have not been able to totally stop drinking or using. And they allow that in a monitored sense, and they allow that in that facility. And so they have the statistics that they have gathered from pulling those people off the street, the statistics that has to do with crime, with the ER use has been tremendous and a tremendous success. And it's kind of surprising. I went through that facility, very nice little apartments. They have meetings there. It's not a treatment center, but they have, I think there's about 200 people that are on the wait list for that, and right now there's about 60 apartments. So it is effective in as far as not just financial, but emotional and medical reasons. So.
Thank you for that snapshot. We're going to hear from our second speaker next. And thank you, Lex Rivers, for joining us today. Lex is the regional manager for Catholic Community Services Recovery Center. He has a master's in social work along with certification as a chemical dependency professional and is a licensed mental health counselor. He's worked with youth, individuals, and families affected by substance abuse and addiction for over 17 years. Lex manages the largest substance abuse treatment center in Whatcom County. Supervises a team of substance abuse counselors, and he'll tell us a little bit more about that and the scale of their work. He also mentors and trains new professionals and practicum students from Western Washington University, Skagit Valley Community College, and is an instructor on chemical dependency and treatment on treatment and counseling skills. What attracted Lex most to this work is the urgency and need for immediate help that addiction and abuse cries out for. Lex is someone, he said this, not me, Lex is someone with a fireman's mentality who tends to gravitate towards the fire. He also feels the individual and community need to face and fight the fire. Over the years of training and experience, he has found most useful the motivational interviewing techniques that he participated in a 2-year clinical research trial. So perhaps we'll hear more about that as well today. Thanks, Lex, for joining us.
Thanks for having me. I have to start out by saying it's intimidating when you're announcing the next topics and they're more interesting than the one you're talking about. So I'll try to make this interesting. Our agency, CCS Recovery Center, we see roughly 1,000 people a year with drug and alcohol problems. And if we had more staff and more room, we might even see more than that. As you know, the need is there. And we see youth and adults, and we do the whole spectrum of services except for inpatient. We take insurance clients, and we see people without any money at all. And we get referrals from the courts, from probation, from drug court, Department of Licensing, medical profession. Sometimes we have special sessions with doctors and nurses. But we also get the person that just decides, I'm tired of this, and they walk in just saying, what can I do? Or you have the mom or dad or the grandma that comes and says, help my kid. Probably the most touching situation is when you get a best friend who comes in and says, what can I do? Or I'm going to bring her from class, will you all see her? And those are very powerful, when a friend does that. So, like I said, we see the gamut. The youngest client I've ever worked with a drug problem is 9 years old, and the oldest is in their 70s. And I'd like to say that I think every client has taught me something about myself, about addiction, and also about what I might be able to do for the next client. And so I'd like to share kind of some impressions of kind of what I've been seeing. And well, we know that drug addiction comes from all different sources. It's not just one thing. There's genetic disposition, there's mental health, there's psychological deficiencies, there's peer pressure, there's family exposure, there's all kinds of pathways that someone can become addicted. And those issues are always going to be with us. There's not a lot we can always, change. Those variables will always play a role. But there's a couple variables that I feel like we can have more influence on and be more proactive. And the two that I want to mention right here is the availability of drugs and the ignorance that we work out of. And ignorance, basically, I think, I don't mean that in a negative, like stupid way, but we're sometimes working in the dark. And we often want to focus on the next generation, our youth, and we need to help them. But one of the fastest growing populations for drug addiction and alcohol abuse is senior citizens. And yeah, you all are a bunch of drug addicts, And part of that is because doctors are not, they're some of our brightest people, but they're not always educated about addiction. And many times in a survey, doctors have said they don't push the subject of alcoholism with their clients. And so doctors aren't always looking for that, or they don't have time in their sessions for it. And they're also writing scripts for a lot of medications and not really knowing, are they drinking also? Because that's a horrible interaction. So families are often reluctant to, tell grandpa he has a drinking problem, or they're saying, well, he's only got a few more years, let him enjoy it. There's that kind of mentality. But the silent epidemic about this is that there are many, many more people who are struggling with the substance use because of loneliness, because of depression, because of anxiety that comes with the set of issues with growing older. And yet there aren't many services ever provided for senior citizens in this. And I feel like that's part of the ignorance side of that, and the availability is just how accessible these medications are. To be able to write a script and to get alcohol and all of that. So I feel like that's an area that we need to address, but we never see it because senior citizens aren't breaking into cars and stealing things. They're not shoplifting alcohol, at least none that I have seen. So so they don't come on the radar. The courts aren't saying they're flooding our jails. And so nothing is seen. And so it's kind of a perfect storm of availability and our ignorance. Doctors have been, about 10 years ago I think it was, that they were really prescribing a lot of opiates, OxyContin, and it was coming onto the stage. And the ripple effect now is people have been prescribed so much of it, and then they get introduced to opiates, and they like them. And now we're seeing the floodgates of heroin addiction because it's cheaper, they can't get the prescriptions anymore, and now they're hooked on opiates. So that's another way where we inadvertently were trying to help maybe people deal with pain, but now we've made it more available for drugs. With marijuana and the whole legalization and all that, I'm not here to say what we should have decided, but I fear that we made a decision based on fiction rather than fact. And because of that, we're going to have an availability like never before. Some of the fiction that people were promoting that besides, youth always tell me, well, it's natural and Jesus smoked it and all that stuff. Well, we know that's fiction, but some of the other things are like, well, let's get the tax dollars. And yet what we found is that with alcohol and tobacco, for every $1 of tax we get, excuse me, $10 is spent dealing with the effects of that medically and physically and all that stuff. So that's kind of that's fiction. Well, this way we can regulate the amount of THC, and that's true. Let's say we do regulate the amount. The black market will then say, well, we have stuff that's better and stronger. So regulation isn't always. And the other myth or fiction is that it's not addictive, and a lot of this is based upon the hippies in the 60s that smoked it, and it wasn't addictive, but it's 5 times stronger now than it was in 1960. And so a lot of the information we're getting is not fact. It is addictive. It's proven to be addictive. And for every adolescent that starts it in adolescence, they have a 1 in 6 chance of becoming addicted. There's a 15% chance. For alcohol, for adolescents, it's 17%. For heroin, it's 20%. So you can see it's roughly in the same neighborhood. The other thing about marijuana that I just think is so significant is that heavy marijuana smokers in adolescence, it's proven that their IQ level can be lowered 6 to 8 points. Yeah, and if you know anything about IQ, your IQ doesn't really change a lot over the course of your life. So for something to be able to shift that is very powerful. And with this is going to come an availability. In Colorado, they have vending machines. Just think about how long it took for us to get rid of vending machines for cigarettes. It took forever. Now they have vending machines. They're also making a lot of edibles, so that are going to be appealing to kids. Cookies, peanut butter with marijuana in it, chocolate bars, ice cream, granola bars. There's a product called Pot Tarts. So, I got to say that was pretty creative, but just think about that, how many kids, and we're not just talking about teenagers, but 5-year-olds who, because marijuana is in the house, are going to have access. 2 people have died in Colorado from the edibles. One reason is because when you ingest it, it takes longer to get the high, so they just keep eating it until they get more. And the other reason is because it's not necessarily, they might regulate that you should only have 1 piece of the candy bar, but how many times have we just said, well, I'll just eat the whole thing? So, this is going to be a trend that's going to be something we're going to be dealing with. They did a poll in Colorado of teens that were in inpatient treatment, and 74% of them admitted that they had used someone else's medical marijuana an average of 50 times. So, that's an indication that it's available. It's someone else might be using it medically appropriately, but they can just go into dad's box and get it. So those are the things that I feel like are issues that we have to deal with. On the positive side, I've seen some things where we have addressed the ignorance and availability, like several years back. How am I doing? Okay, cold medicines. People were getting high on cold medicines. And we actually had a couple students die from that. We became more aware of this, and nationally we became more aware of this, they were also getting the cold medicines and DXM to help make meth. So what did we do? We took that product off the shelf, and now you have to go to the pharmacist and get it. That slowed down the availability of it, and I think that was pretty smart. Plus, we became more educated about it. And I think that's a good example of what we can do when we decide, okay, we got to get smart with this. Parent Matters is an organization that is really becoming active about educating parents in high school and middle school about, hey, this is a real problem. They're locally, and I think they've been making inroads in places that we couldn't. Carole mentioned the brain disease. This is exciting news because no longer are we just looking at it as a behavioral problem. We are now able to look at the brain and see what's going on, whether it's drugs or gambling. They're now even studying the effects of peer pressure on teens. And they can see activity going on in the brain. So we're at exciting times in terms of maybe we can get to the root of this, and if nothing else, at least we can validate that this stuff isn't good for you. The other trend, one other trend about the drug use of teens, the scary thing that I'm seeing is that it used to be someone might use drugs in an experimental way in middle school, mostly in high school, and you had about 2 or 3 years that you hoped they'd figure it out and grow out of it. You know, you say, okay, well, he's not getting in too much trouble, and hopefully by the time he's a little older, he'll grow out of it. But what we're seeing now is that kids are quickly going from experimental to hardcore use in a matter of months rather than a matter of years. And so the brain isn't having time to catch up and sort through this and all this stuff. And you might have someone that starts smoking at 15, and by the time they're 16, they're using heroin, you know, or they're smoking pot every day. And so the athlete is no longer going out to practice, you know. They're no longer working on their grades. So it's a much quicker slope that we're seeing. The other new trend is that we're starting to understand another component. There's always been mental health, and there's been CD, chemical dependency, and these are issues that need to be addressed. There's a third area that's emerging that I think will actually have its own voice too, and that is the issue of trauma. We're becoming more and more aware of what trauma does to the brain development, what it does to the emotional system, and how that very quickly gets connected with mental health issues, but also gets very quickly connected with the need for chemical relief. And so, even though it's a tragic concept that trauma is such a big part of our society, we're at least starting to see that we need to address it. We need to reach out, especially with children that are going through traumatic events. It might explain why this child is not behaving in class, and it offers some hope, so that rather than sticking that kid in a behavioral problem label and set up for failure after failure, we might now say, well, let's look at what this kid is facing, and we need to understand it. So those are kind of the trends that I'm seeing.
Could you speak specifically to standard protocols that are used in your program and how those might be changed if there's a mental health component in addition to the chemical dependency component?
Well, there already is a mental health component in every assessment we do. There's a Dimension 3 where we do a screening of what kind of issues are going on. Is someone self-medicating and they don't even know it? They could be bipolar and they find that this drug balances them out. So that's always been a part of our assessment. Where it might really help is if we have more accessibility to counseling. Because a lot of times we have a co-occurring group where we support people with more acute mental health issues. But if we start to combine the two with mental health, hopefully we'll be able to refer more people to get a counselor.
And in regard to that, is the socioeconomic gap part of that challenge for accessing the counseling?
Oh, yeah, absolutely, yeah.
Could you speak more to that for people to understand the reach that exists now and the demand that is out there not yet served? Yeah.
Well, first I would say that socioeconomically, those that are poor and struggling or working poor have a whole level of stressors that people don't have if they're socioeconomically in better straits. So there are issues with that. But regarding getting access, if someone has insurance, they will probably be able to go to a counselor and pay a copay. But usually the ones who need to go get, subsidized counseling, they have to wait for maybe a month to get an appointment. And if they miss that appointment, it's going to be another month. And so it can be a revolving door of getting services.
We do have a few questions we want to follow up with the panel, but first, thank you, Lex, for sharing your perspectives and stories. Some of the questions our committee wrestled with over the few months that we were putting together both of these programs was how do we understand how to help people prevent from taking up this destructive habit? So prevention's a big part of the field. Could you speak more to contemporary prevention and the ways that you're working with it now?
Well, I did mention that in the 80s there were school programs that were developed, and then a period of maybe 15, 20 years those programs really not quite shut down, but almost, because of funding reasons. Now they have reestablished counselors going into the schools and being available for people. I believe, I'm not sure, but I think CCS has school programs. Is that correct?
We do in another county, yeah.
Okay. So, that's one of the things of having someone available, where the kids are. The other part of it, too, is Lex spoke to the fact of medications. We have, for the first time, heroin addiction has been seen as a big problem for teenagers. And as he spoke about is that, with the prescription, with the narcotics available to parents, they're also available to the teenagers. And so they can get started in that way. And so really the education piece of it for the medical field and for parents, caretakers of children, looking at what's going on with their drugs, what is going on in their home, to really doing some more education. So education and looking at providing help to where the kids are is really essential, I believe.
I think that we have to redefine what prevention is. I think, yes, it's education, but education just isn't doing it enough, and the prevention would look differently in different places. With drug court, I think it's a great investment. You have a prevention there because you have people that are already destructive, but we want to prevent further destruction, and we want to prevent further costs to the system and all that. So that's a certain kind of prevention. I wish we could define prevention as having a welding class or a shop class in high school or middle school, because so many of our kids are failing and then they give up. And there's nothing, if you don't want someone to hold on to that, then give them something else to hold on to. And if they're failing school or they're not just interested in sitting down in class, but you give them a hammer and they do something, that could be a sense of prevention. I think we need to redefine what prevention does.
And I have one more follow-up question, because I know this is on many people's minds. We have a big jail development project in the community, and the behavioral health plan services ties some of those services to the jail facility. Could you share your perspectives on bringing the behavioral health treatment interface into that complex where it is a jail site? Any thoughts on that?
I know for years the hope has been to, with more space being made available in the new jail, to have a therapeutic community in the jail system. I think that speaking with the county coordinator the other day, with who actually monitors the funding for programs like this, the challenge is there. There is a program that is developed now that people have been able to go in and do assessments in jail and so on, but there's money put towards an actual program that helps people in the jails here. They have that in other programs, in prisons especially, where they have chemical dependence programs that people can go to. So I know the persons involved in the jail have been very proactive in promoting having that therapeutic community, and hopefully with some of the funding, if it can be directed. There's always, with funding, there's always so many issues to consider, and it's really important to put that money toward where it's going to do the most good. So I know that is something that is on the table right now, of getting something good going for our jails.
Thank you. Lex, thoughts on that in
Yeah,
your field?
I currently supervise someone who's a behavioral specialist in the juvenile detention center. And it's just amazing how many kids, it's the first time their mental health stuff has surfaced. They've been arrested many times, but no one's found out that they're getting beaten up at home, or that they have depression, or they hear voices, or they have been traumatized. And so that allows for proper diagnosis. Also, sometimes it's the first time that kids actually feel like they've gotten heard, and it builds a good relationship, or a bridge for if this person, I can connect with this person, maybe I don't feel bad about going to get help somewhere else. So I can only imagine that the same dynamic would happen in the adult.
Thank you. And now it's your turn. We have some folks in the back, Don and Joe, have some microphones, and we're going to ask, if you'd like to ask a question, that you put your hand up. They're going to bring you the mic, and you're going to wait for the mic, because this is actually being taped and put on video, so we want to get your question on the audio. Anyone have a question for either of the speakers today?
Hi, I'm Steve Giordano. My question has to do with the trauma you mentioned as a contributing factor toward addiction. I assumed you meant physical, like in the ER from an accident, but on second thought, I don't think you did. Could you clarify that?
What about?
What type of trauma contributes to someone possibly becoming addicted to something?
Trauma is defined as any situation where you feel like you're in threat of physical harm, or that you've watched someone else. So the whole emotional system has been skewed. It doesn't know. It causes anxiety, fear, hypervigilance. If you look at some of our soldiers coming back, you have that hypervigilance, you have that constant fear. The fact that they can't sleep causes mental health issues and stuff like that. So without knowing it, people with trauma oftentimes, they don't want to feel the fear. They don't want to feel these emotions, so they drink and they numb themselves. Or when they're high, they're relaxed. And so all of these are issues in which someone, whether it's a child or an adult, they have a difficult time sitting with this pain, this psychic pain. Does that answer your question? Okay.
Carole, do you have anything to add in your work with family systems?
Yeah, the stress that emotional situations that occur with children produces the chemical norepinephrine, which is the fight and flight. And so when you think of ways of, especially when you're looking at kids, how do you anesthetize yourself from that, and when drugs are available? And so it definitely, for many, many people, when you really explore, when they started using and what was going on in their environment, that is one of the issues. It's a way, and in some ways, it's by especially teenagers and children using drugs, it's almost like a survival mechanism that to escape that trauma. It's not a good thing, but some of the people who turn to alcohol and drugs may have committed suicide, truly, if they hadn't found some resource. Now that sounds contradictory because of course we know what alcohol and drugs do, but it is almost every person that I have counseled has had some emotional trauma in their life. Sexual abuse, child abuse, there's such a connection there. And, dealing with that issue, you can take the alcohol and drugs away, but then you have that issue to deal with, the emotional issue that needs healing.
Can I say one thing?
Yes, please do.
Well, the other piece of this is that quite often people are traumatized more than once. And so this complex trauma, what they're finding, early research is showing that if someone has an initial trauma, they might be able to work it back down to a calm state. But each time there's another trauma, it gets harder and harder to get back to a normal state. And so early thoughts are that after the fourth major trauma, and we have to be careful what we say is trauma, but they're not sure if someone can come back from that. So if you're looking at someone that's had multiple deployments or someone that's been repeatedly abused, it's very difficult.
Thank you. We have a question over here with Don, and then put your hand up. We've got some over here.
I'm not clear on kind of the A to Z of what we currently have in Whatcom County. What do we have in services right now?
For drug and alcohol? Okay, Carole, you want to?
Sure. There are several outpatient treatment centers now. I think there's probably about 5 major ones, wouldn't you say? And some of those are dual diagnosis or co-occurring disorders. So we have 3 main ones, CMAR, CCS, and Whatcom Counseling Clinic all have dual diagnosis programs. There's a number of multiple counselors that are out there in the addiction field that are separate and that are on their own. We currently don't have an inpatient center. St. Joe's had a wonderful program some years ago, Recovery Center at St. Joe's, and that was shut down several years ago. So currently we don't have any inpatient treatment centers here in the area.
And I would say that we don't have enough services.
Yeah.
The past recession and the budget cuts, a lot of agencies
Yeah.
had to close because they couldn't keep open.
New question over here with Joe.
2 quick questions. The role of diet in addiction. In the early 60s, 70s, people were talking about the organic movement and having good food, and the lack of good food can make one be more prone to salt and sugar, which was one of the first kind of early addictions and stuff like that. Also, the second question is the role of our DNA. Are we not just a drug-prone species?
You want me to jump in? Or
Sure, you go for that one.
I think we're a drug-prone society.
Yeah.
I don't think we're a drug-prone species. If you look at mental health counseling, the brain actually likes some stress, but most counseling is focused on how do we get you happy. And so I think the brain can survive just fine, a lot of times, but we're convinced in this society we need to go to that. So I think we're a society that's prone to that. And as far as nutrition, I think you're right on the money. Realistically speaking, it's almost a luxury. We try to do something on nutrition, and all of our clients really need that. But it's almost a triage thing of, well, hopefully we'll get to that once we settle all these other major issues. But that would be another example of what prevention looks like. Can we get our kids to eat better and understand that? I think that's another form of prevention.
We've got a question here. And, Joe, you got one.
Did you want to answer that?
Go ahead. It's
What
close on
effect
time.
is the new health program going to have on drug and addiction counseling in general, especially in this local area? Do you have any kind of thoughts on that?
What is what?
The new
What's the effect the new not Obamacare, but the new
Healthcare Act.
healthcare program going to have on addictive counseling in this area locally?
I don't know if anyone really knows the answer to that question in any area.
All I was going to say is, they have said, and we have said, that it makes it less expensive for people in the lower income brackets. And from what I'm hearing, and I'm an ex-counselor, or a counselor, period, I saw a lot of kids in continuation school where I worked that were in a low area of, and had a lot of addiction problems. And I think we do that in society. So would it make it easier for them to get treatment? It sounds like it's harder for them to get treatment from what I'm hearing right now. It takes them longer. It takes a longer bit of time. There's no money around.
I would say two things. One, we're still transitioning. You know, we don't have the insurance companies that are going to be really responsible for supplementing the low income and all that kind of stuff. So I think in another year or so, we'll have a better idea of that. The one good thing that I see that can come out of this whole medical is it's a shift from acute care to chronic. Rather than, hey, you go there, get fixed, and now you never have a drug problem, we're starting to look at this as, you know what, maybe we need to look at this as just like diabetes or anything else. You need to get a checkup. You need to go in once a month or once every year to just kind of see how you're doing with that. And so with this kind of universal care, I'm hoping that that'll transition to where mental health and drug addiction will seem more as a chronic thing we can service.
Thank you. We have time for one more quick question.
I just want to add something
Sure,
real
very
quick.
brief.
In response to that question, too, there are new trainings that are coming out and new screening tools that especially it's screening, brief intervention, and referral to treatment, that people, not just counselors, can be trained into doing that screening, and the hope is getting into the hospitals and other places, and so that they can get whatever, if they just need maybe a couple of counseling sessions or they need inpatient treatment, that screening can occur in more places and not just reserved for chemical dependency counselors.
Thank you. One.
This question has to do with the destructive element of drug and alcohol abuse, and the risk to society and your responsibility as counselors of identifying those people who are either so close to destroying themselves or others. Do you have the ability to keep them from going out and buying a weapon?
Man, that's a loaded question in more than one way.
So the question is, do you have the ability?
No.
No.
The only thing we would do is if they said something like, I'm going to go kill this person, we would have a duty to warn if we really saw that as happening. But no, this is America.
That is one of the few reasons that we have the duty as counselors to report if there's child abuse going on, elder abuse going on, treason, and recognition that they may be harmful to themselves or others. We have to report that. It's a felon if we don't, but that's about all we have.
And were you wondering more about the chemical dependency or the mental health?
Yeah.
So I thank you both for sharing, not just today, but decades of your life caring for people that a lot of people lose patience with, caring for families who suffer year after year and generation after generation. And I know personally and professionally that you both have not just brought hope to this room, but you've brought real hope and real health to people's families. So our community owes folks who work on these front lines a lot of debt. This is not a high-paid line of work.
No,
There's
it's
a
not.
never-ending
It's not.
stream
Let me
of
emphasize that.
suffering coming in, and there's an ever-increasing demand for skillful means. So thanks for giving us a few ideas about how to be more skillful in our care of the people we love, that might be in our 1 in 4, and how we as a community take a more assertive and an aggressive stand to say it matters here, how we care for these folks. And the fact that we have a county-funded system, that we as Whatcom County voters in 2009, we voted as a community to tax ourselves, to create resources to care for this part of our community constituency and our families and our friends. So I thank you all for coming today on a really nice day in Whatcom County in the summer.